Our next presentation provides compelling evidence of the link between substance use and women and infants, morbidity and mortality. We will reserve some time for questions at the end, about 11:10. It is my pleasure now to introduce Glenda Ramirez. A Yuma native, Glenda serves as the maternal and child health epidemiologist at ADHS, where she currently conducts monitoring and reporting on maternal health outcomes related to morbidity and mortality. She also supports quality improvement and evaluation efforts focused on maternal health services and outcomes. Welcome, Glenda.
Thank you very much, Jeanette. All right. Hi, everyone. Again, I'm Glenda Ramirez. Thank you for being virtually here to attend this session and this summit. I'm the maternal health epidemiologist with ADHS, and as you see in the title, I'll be presenting on current trends in maternal mental health and substance use and the impact on women's and infants' morbidity and mortality. So a couple of my objectives for the presentation today are to provide an overview of recent findings focused on what was mentioned in the title. With the help of Dr. Sarah Keller-Halls, we'll be sharing information on maternal deaths related to mental health, substance use, and ACEs in Arizona. And then finally, we'll be sharing data on NAS in Arizona. Before going any further, we would like to let you know that during this presentation, we are going to talk about some sensitive topics, including but not limited to maternal death, miscarriage, suicide, and homicide. We do ask that you take care of yourself in whatever way you need, including stepping away from this presentation now or later. So when we think of maternal health outcomes, we tend to think of them occurring on a spectrum. And this pyramid shows the range of outcomes among pregnancies that typically occur with a live birth. Thinking of what we see at the very bottom of the pyramid, most births are relatively uncomplicated with a healthy mom and healthy baby. But there are some really serious complications that can happen during pregnancy, during delivery, or after a woman has a baby. When these complications happen, they can have a significant long-term health consequences or even result in a woman's death. I'll touch on a few different topics today, but most of this presentation will be around pregnancy-associated deaths. And when we say pregnancy-associated, what we mean here with associated is that the death would have happened whether or not the woman was pregnant or pregnant within the last year. But before jumping into that, I'll go ahead and provide a quick glimpse of overall maternal mortality and access to care. So I'm sure many of you have seen or heard that pregnancy-related maternal mortality in the US has been increasing, and we are the only developed nation in the world to be seeing these increasing poor maternal outcomes. And here by related, we mean deaths that can happen directly due to the woman being pregnant. And as you can see this trend here, where pregnancy-related mortality ratio in 1987 was over 7 maternal deaths for every 100,000 live births. Then looking at 2017, where the rate was over 17 maternal deaths for every 100,000 live births in that year. And considering the factors that impact maternal health, we know that there are many factors that are associated or causing these poor maternal health outcomes, right? But oftentimes the blame is quickly put on the healthcare sector, stating that access to maternal health care is limited in certain regions, quality of care varies by facility, and that cost of care is a barrier for many families. And these are all absolutely factors that we should be considering. But we also know that there are many other things impacting maternal health outcomes. And that's what is shown in this slide. I don't expect you to read every detail in this moment, but we do like to share this because it shows all the many factors that could potentially influence maternal health. So looking at the top, this includes broadly social determinants of health like housing, transportation, etc. And thinking more specifically of factors ranging from patient factors to systemic and community factors. and within each of these more specific factors. So all these things can impact maternal health before, during, and after pregnancy. So again, keeping in mind what we know, that it truly can be, and most often is, a multifactorial concern. And one of the key components for achieving optimal maternal health outcomes is access to care, and specifically participation in prenatal care. In Arizona, we have seen an increasing lack of participation in prenatal care, particularly since about 2009. And again, there are a lot of different reasons why women and families may not be attending prenatal care visits, and easy access to care is one of them. So access to care was also assessed in the March of Dimes Nowhere to Go study. These maps of Arizona show 3 different measures of access to care. So the first map in blue shows areas of Arizona where there are no birthing facilities. We have 3 different counties with no birthing facilities, and several more with too few facilities. The middle map in green shows the availability of obstetric providers. 2 Arizona counties have no obstetric providers, and several others have too few. And the last map in orange shows women without health insurance. So you can see a large portion of our state has low access to health insurance. And so each of these factors to maternal, factors affect access to maternal health care in our state. So nationwide, concerns have really sparked studies and interventions focusing on maternal mental health and maternal substance use disorders, both together and as 2 separate concerns. And reason being that we know that nationally, at least 1 in 5 women experience a mental health condition, and we know that maternal substance use is also increasing. Recent studies have shown that maternal opioid use disorder has had a 4-fold increase. Methamphetamine use had a 3-fold increase, and marijuana use recently doubled among pregnant women. In addition to these findings, studies have shown that stigma revolving around mental health and substance use can be a deterrent for expectant and postpartum moms to seek care for these conditions. So it's pretty evident that untreated mental health and substance use disorders can really have an impact on women and mothers. For instance, adverse obstetrical outcomes, loss of sleep, difficulties with parenting and bonding, and many potential others. But unfortunately, truth is that the impacts of these untreated conditions can really go beyond impacting moms and birthing people. There are also poor health outcomes that infants and family units face when these conditions go unaddressed. For instance, difficulties with parenting clearly affect the infant, and they can happen as issues with breastfeeding, limited bonding, or with early childhood development. Also thinking of the family unit, paternal postpartum depression can occur as well as marital dissatisfaction. So in a moment, I'll touch on specific characteristics and outcomes for maternal mental health and substance use, but I wanted to take at least a moment to reflect on the many ways that families can be impacted by these untreated conditions. So now I'll just go ahead and move into some of our state-specific data on maternal mental health and substance use-related deaths outcomes here in Arizona. So the maternal data that I'll be presenting on comes from the Arizona Maternal Mortality Review Program, or MMRP, which was established in 2011. Arizona is required by law to review all maternal deaths that occur within 1 year of pregnancy. We have a team that reviews these cases, and it is a multidisciplinary group of dedicated individuals that have different combinations of clinical and community knowledge and background. So these external partners are social workers, physicians, mental health providers, a very big mix. And within the agency, we have a small but mighty team that collects medical records, police records, and several others. They review these records for each case, summarize the findings, and present them to the Maternal Mortality Review Committee, or MMRC, and that's typically on a monthly basis. So when the committee reviews these deaths, we are aiming to answer the following questions about each death. Was the death pregnancy related, meaning would she have died if she had not been pregnant? Or did she happen to just pass during the year after pregnancy? What was the underlying cause of death? Death certificates almost always state an immediate cause of death, but they rarely describe other things happening in her life that led to this death. So for instance, if the death was a drug overdose, the death certificate won't say that this person had a history of mental health conditions that weren't adequately treated. If any childhood trauma was experienced, or if she maybe experienced intimate partner violence in a relationship. So all these things may have impacted her path leading to the overdose, but the only way to understand those things is through this review process. Also, was the death preventable? If so, what factors led to the death? And then finally, what recommendations could the MMRC make that would help prevent these types of death in the future? So as part of the review process, the committee answers 2 questions for each death that indicate whether mental health or substance use contributed to the death. For the data that I'm about to show you, each of the deaths had a yes or probably checkbox marked for mental health and or substance use disorder. So between 2016 and 2018, we had 203 pregnancy-associated deaths. Of those, 99 were related to mental health or substance use. And that proportion is shown at the bottom left, showing that it's almost half, which is a pretty considerable proportion. But even when we look at pregnancy-related deaths in purple, so those deaths more closely or directly tied to the pregnancy itself, 30% or almost a third of those deaths were related to mental health or substance use. So from these, the Maternal Mortality Review Committee determined that all but one of these deaths related to mental health or substance use were preventable. That's 98%. So what this means to us here at ADHS is when we look at this data, is that there are things that we can do as a system, as providers, as communities, and as families to prevent these deaths moving forward. When we think about preventability, it's important to think about when these deaths happen so that we know where to focus our prevention efforts. So really considering when during their perinatal period women are most at risk. In Arizona, almost 60% of maternal deaths related to mental health or substance use disorder occurred in the late postpartum period, between 43 and 365 days postpartum. So one main reason why this is so important to note is because for many of these women, this is when their access or their Medicaid coverage would stop, when their home visits could stop, and when their postpartum follow-up visits stop. With that said, if we are not doing a good job at ensuring that women are connected or reconnected into primary or well-woman care, we really are leaving them vulnerable at a time when certain conditions, especially conditions related to mental health and substance use, are potentially becoming more exacerbated. So when we look at disparities in race and ethnicity, we like to show a comparison of what the population in Arizona looks like, or particularly live births, and compare that to the total population of maternal deaths. If there are no disparities in mental health or substance use related deaths, the proportion of live births per racial ethnic group would equal the proportion of maternal deaths for each racial ethnic group. Unfortunately, that is not the case for 2 populations in Arizona, and that is AIAN and white non-Hispanic women. For American Indian, Alaska Native women in Arizona experience the greatest disparity in mental health and substance use disorder related to maternal deaths. So looking at AIAN group, you can see that 5.9% of all live births in Arizona were AIAN women, yet of all the maternal mental health and substance use deaths related, 11% were only AIAN women. And this is similarly for white non-Hispanic women. When assessing cause of death, we found that over 1/3 of pregnancy-associated deaths related to mental health conditions or substance use disorder were due to poisoning, overdose, intoxication, as seen on the death certificate. When we look at cause of death, it makes sense that these three were the leading causes for mental health and substance use disorder deaths, followed by suicide. But it is important to note that not all mental health and/or substance use conditions lead to an overdose or suicide and can impact all components of a person's life. So when we look at natural deaths in particular, we know that mental health or substance use can impact people's motivations to keep up with a chronic condition, among other things. It can impact motor vehicle accidents and can impact people's exposure to or involvement with violence, all of which made up most of the cases that you see on this slide. So in terms of Arizona location of deaths, we found that more than half of pregnancy-associated deaths related to mental health conditions or substance use occurred in central Arizona, which to some extent makes sense since central region is where Maricopa County is located, clearly the most populous county in Arizona. But what's also important to note is that while most deaths occur there, maternal mental health and substance use disorder related deaths are actually overrepresented in other regions of the state, meaning that the disparity actually lies in the southeastern, northern, and western portions of Arizona. So again, comparing deaths to live births, 17% of live births occurred in the southeastern region. Yet 21% of all maternal deaths related to mental health or substance use disorder were in the southeastern region. And again, thinking back on our maps from the March of Dimes study, these are also the areas that likely have less access to mental health care and substance use treatment. So since this data includes deaths that occurred between 2016 and 18, it includes data from a key point in the opioid epidemic. And you can see that opiates were the most commonly used drug type among maternal decedents with a mental health or substance use disorder checkbox marked. But we also see a lot of methamphetamine use, cocaine use, GABA agonist, and others like alcohol and marijuana. And finally, regarding drug characteristics, here you see information on the amount of drug types used. Recently, substance use prevention has been very centered around preventing polysubstance use. And from our data within the MMRP, we found that the majority, or almost 70% of maternal deaths with an indication of substance use disorder were using 2 or more types of substances at some point in their lifetime. And so we recently also started taking a deeper assessment of maternal deaths in Arizona by looking at health outcomes and their relation to ACEs. And with me now is Dr. Sarah Keller-Halls, who's a maternal fetal medicine fellow at University of Arizona, and she'll go ahead and touch on her investigation. So Dr. Sarah Keller-Halls, are you here with us?
Yep. Good morning, everyone. Can you all, hopefully you can hear me okay?
Yes.
Right, perfect. So I'm excited to talk a little bit today about adverse childhood experiences, as well as touch on our study that I'm conducting with Dr. Gray and the Maternal Mortality Review Committee, looking at adverse childhood experiences in our maternal mortality population. Am I sharing my, oh, perfect, thank you. So just to orient everyone to adverse childhood experiences for anyone on the line who does not know, in 1998, Kaiser and the CDC published the original ACE, or Adverse Childhood Experiences study. And this study was one of the first studies that aimed at evaluating the relationship between health risk behavior and disease in adulthood with the breadth of exposure to adverse childhood experiences in childhood. And this study was conducted from 1995 to 1997 and ultimately published in 1998. And over 17,000 members of Kaiser Permanente filled out confidential surveys regarding their childhood experiences and their current health status and behaviors as an adult. This study grouped the adverse childhood experiences into three major groups. One being a group of abuse, including exposure to physical, emotional, or sexual abuse as a child. Another group of neglect, including exposure to physical or emotional neglect. And then a third group of exposure to family challenges as a child, including a family member with mental illness, a family member who was incarcerated, exposure to a mother being treated violently, exposure to substance use, and divorce. And this study demonstrated that about 61% of adults surveyed across 25 states had at least one type of adverse childhood experience before the age of 18, and 1 in 6 adults experienced 4 or more types of ACEs as a child. The study also highlighted that at least 5 of the top 10 leading causes of death are associated with adverse childhood experiences. And if we were able to prevent ACEs, we could reduce the number of adult depression by 44%. Next slide, please. Since this original study has been conducted, there have been many other studies that have subsequently evaluated ACE exposure and the impact on health and well-being. And studies have demonstrated that there is a graded dose response with adverse childhood experiences and the negative health and well-being outcomes as adults. In other words, an increased number of ACE exposure increases the risk of negative health outcomes. And these adverse childhood experiences can increase the risk of injury, sexually transmitted infections, maternal and childhood health problems, including increased risk of teen pregnancy and pregnancy complications. They also can increase the risk of a wide range of chronic diseases leading to death, such as cancer, diabetes, heart disease, and suicide. Adverse childhood experiences are also associated with social determinants of health, such as living in under-resourced or racially segregated neighborhoods, frequently moving or experiencing food insecurity. All of these conditions can cause toxic stress that can affect a child's brain development, their immune system, and their stress response. This ultimately can affect a child's attention, decision-making, and learning. And children who grow up in these toxic stress environments may have difficulty forming healthy relationships. They also may have unstable work histories. They can struggle with finances, jobs, and depression throughout life, which then subsequently can be passed on to their own children. And so these two figures are adapted from the CDC with the overwhelming impact that adverse childhood experiences can have negatively on your adult health. Next slide. There is emerging data about adverse childhood experiences and adverse pregnancy outcomes. And this is a figure that was adapted from a recent study that was published in the Journal of Obstetrics and Gynecology. And women and several racial or ethnic groups are at greater risk of experiencing adverse childhood experiences. And so this emerging data regarding pregnancy is very important. And in this particular study, this was a retrospective cohort of women who were surveyed regarding their exposures to adverse childhood experiences while they were pregnant, and their subsequent pregnancy outcomes were evaluated. And in this study, there were 1,274 women that were surveyed, and 71% of them reported at least one ACE, and 23% reported a high ACE score, which was greater than or equal to 3 adverse childhood experiences, which were noted on the first slide that I started presenting. And this study demonstrated that a high ACE score greater than or equal to 3 increased the risk of hypertensive disorders of pregnancy, preterm birth, and perinatal depression. And this figure within the study really highlights the interrelatedness of social determinants determinants of health and the increased risk of adverse childhood experiences, which subsequently increase risk of clinical mediators such as tobacco use, other chronic medical conditions, and obesity, which ultimately can lead to adverse pregnancy outcome. So this data really amplify the importance of the CDC's campaign, as well as Arizona's campaign to prevent adverse childhood experiences and improve the health and emphasize the potential of prevention to mitigate some of these intergenerational stressors. And do you want me to talk about our study, Glenda, or will you talk about that?
If you can briefly just touch on it a little, just I think we might be getting close to time. Thank you.
Sure. So our study is that we essentially are evaluating ACE exposure in our maternal mortality population, and we have looked at 2018 and 2019 maternal mortality cases. And our study has demonstrated that having at least one documented adverse childhood experience increases the risk of maternal mental health diagnosis among our maternal mortality patient population, and also increases the risks of a pregnancy-related death to substance use disorder in comparison to the maternal deaths that are not directly related to pregnancy. There are many findings that we are noting throughout this study, and we will be hopefully publishing it within the next 6 months. So news to come on that in the future.
Great. Thank you so much, Dr. Keller-Halls, for that. And so another aspect of the work we've been doing here through our agency's Bureau of Assessment and Evaluation, the epidemiologist Alexis Griffin and Dr. Shane Galloway led an investigation on outcomes related to NAS here in Arizona. So neonatal abstinence syndrome, or NAS, is a group of conditions caused when a baby withdraws from certain drugs they are exposed to in the womb before birth. So some of the signs include body shakes, poor feeding, and breathing problems, among several others. This investigation looked at confirmed and suspected NAS cases here in Arizona from 2017 to 2021. On the left, you see the case count separately for confirmed and suspected cases, which shows 938 in 2021 alone. And on the right, you see the rate of confirmed NAS cases shown for every 1,000 newborn hospitalizations. And as of 2021, we saw that for every 1,000 newborn hospitalizations in Arizona, over 11 of them were found to have NAS. So both of these graphs show us that there has been an increase in both NAS cases and rates here since 2018 in the state, according to the Arizona Hospital Discharge Database. And so here we see NAS rates for 5 years grouped together. We see the overall rate in Arizona in the gray line, and in the bars, we see rate across the different racial ethnic groups. And in this data, we can see that the rate of confirmed NAS cases was highest among AI, AN, and white non-Hispanic infants. The team mentioned also assessed the combined 5-year average rate of confirmed NAS cases by varying geographical regions in Arizona. And here we see the rates by county, and we can see the highest rates were in Pima, Gila, and Maricopa in that order. The team also looked at specific regions, and by city, Apache Junction and Tucson had the highest rates. So as mentioned earlier, the Maternal Mortality Review Committee, as they are reviewing each case, also come up with recommendations for improving maternal health outcomes and for preventing future maternal deaths. Similarly, the Child Fatality Program also develops recommendations for preventing future infant deaths. Both the Arizona Maternal Mortality Review Committee and the Child Fatality Review Committees work very diligently to put out recommendations to improve maternal and infant health outcomes. We unfortunately don't have time to walk through all of the recommendations today, but we would like to point out that the agenda for this summit was built in line with these recommendations. So you will be hearing this information throughout the summit. However, if you would like to review the recommendations more in depth, please go to our website to review the following reports, which are also available on Whova. And so that's all we have for you today on this. Thank you so much for your time and attention. If we have time for questions, I'm happy to take them. Otherwise, also feel free to connect with me through one of these 2 emails that you see listed on this slide. Thank you.
Thank you, Glenda. That was a wonderful presentation. And I just want to reiterate that you can get all of these reports on HUVA by checking on them. They have direct links, and also at this website that Glenda's put up there so kindly. That was the only question we had, was how to access the PowerPoints and the reports. So I think everybody's clear on that. Make sure you go through HUVA or go directly to the maternal health reports. Thank you.